1, 2. Okay. Let me see. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Maybe I'll give just another minute or so, and then we can get started.
Okay, thank you.
GloCal Fellows. All right, GloCal Fellows, welcome to our January Career Development Series. And today we're very excited and honored to have Dr. Michael, I want to make sure I say your last name right, Mwachiro?
Yes, that's perfect.
Okay, great. Dr. Mwachiro is a consultant general surgeon and interventional endoscopist based in Tenwek Hospital, Bomet, Kenya. He's also the director of the endoscopy department, as well as the program director of the general surgery training program. He's a founder member of the African Esophageal Cancer Consortium and past chair of the steering committee. He is an alumnus of the African Cancer Leaders Institute and a former UCSF GloCal fellow. His research interests are gastrointestinal cancer, with a focus on esophageal cancer and surgical education. He is currently the Secretary General of the Surgical Society of Kenya and the chair of the Education, Scientific, and Research Committee for the College of Surgeons of East, Central, and Southern Africa. So it's such a pleasure to have Michael here today, and I will have him share his work with all of you. And I've told Michael that we'll have about, say, last 15 minutes or so for questions and discussions. So Michael, welcome.
Thank you. Thank you very much for the warm welcome and for the introduction. It's really a pleasure to be here. I'm actually sharing my screen as I talk, but I would like to walk you through my journey. I know this is a career, the focus is on career development. And so partly I wanted to talk about my own journey as I went into research and how that has impacted, my practice. So the title of my talk is Leveraging Global Collaborations for Research, Training, and Mentorship in Africa. Just to orient, I know everyone knows this, but this is a map of Africa, and I'm in Bomet County, which is right here, and that's where Tenwek Hospital is. I was born down on the coast, did most of my training in Nairobi, and then moved on to stay at Tenwek Hospital. This shows you in a snapshot the different things that I do. So this is Tenwek Hospital. The endoscope unit lives here. This is the theater complex, outpatient clinics, wards, and then staff housing surround the campus. There's a beautiful river and a waterfall down here. So it's a lovely place to come and visit. Part of my time is spent with the trainees on the surgery program. And you can see this picture here, which we take every year, shows all the trainees for the different programs that we have here, including general surgery, orthopedics, cardiothoracics, neurosurgery, and recently obstetrics and gynecology. Another fraction of my time is spent on research. And as you heard, I'm a founder member of the African Esophageal Cancer Consortium. These are the countries that form the consortium. We started as research institutions, but that soon quickly morphed into clinical care and other aspects. But it's been a pleasure to watch this grow over the years. And one of my mentors, Catherine Van Loon, is part of the consortium, and a few of the people that I've been working with at UCSF. Then my other life is, of course, doing the training in Africa through the College of Surgeons of East, Central, and Southern Africa, which spans actually the same belts that you can see, with a few additional countries like Botswana, Rwanda, Burundi, Uganda, South Sudan, Mozambique, and Mozambique, sorry. And we train surgeons across the continent, and the goal has been to increase the surgical capacity for the continent. So all that culminates to what I do, which has been really focusing my work on esophageal cancer research over the years. This is the other group that I spend more time with, and that's the endoscopy team. These men and women have devoted their time to taking care of our patients here. This picture is very recent, and you can see here the gender balance changed over the years. It's actually half now, but when I joined the unit in 2009, 2010, it was all male actually. There were no ladies on this team. So this is a testament to the growth that has happened over the years. So where did it all start? I will truncate this story to the University of Nairobi. This was actually towards the end of my training. I really enjoyed sports, as did many of my classmates. And here we had just won one of the soccer tournaments. But really my love for research started there because I was partnering with some of the postgraduates who are doing either their theses, and one of the consultants was doing a project on pediatric research. And so every holiday we would spend time collecting data. And so that began my journey into research and publishing. And so I'll be talking about a tale of three cities. One is, of course, endoscopy and research. The other bit is surgical education. And the last bit is mentorship. And I think all of these are interconnected. So as you all know, for research, when you see something, document it. And then after you document enough, usually you look for ways to report it. This was one of the, every so often in Tenwek, we have hailstones. And on this particular day, there was enough that the entire complex was covered in ice. And so many of the staff had a field day playing in our local equivalent of snow. But I put this picture just to say that research can start from very mundane or obvious things, which you would look at and say, oh, but we always have this every so often. But to somebody else who's never seen that, they would be really fascinated to see that, what did you find? And so never lose the curiosity to do this. The other thing is about the surgeon scientist. And, you know, for us who are in the surgical space, many of the surgeons don't go into careers in research. And so I have been thinking a lot about this, and I found in my readings something called the paralyzed academic investigator disease syndrome that was described by Joseph Goldstein. And he talked about it as a condition of inappropriate training that impairs even the highly motivated young investigators. And his remedy was that you needed a dose of basic science training, a dose of technical courage. And when you look at this tongue-in-cheek, surgeons usually, because of our nature and what we do, it's a right combination of training, personalities to be natural leaders. And so as you do in the OR, this would translate to the research. However, there are gaps because for you to do research, you need to be prepared. And so for me, my journey into research is tied to my journey into surgery. And I'll give you a little bit of background, and this background will be tied to the research that I've been doing. And so as we all know, survival for esophageal cancer and for many tumors is poor when you have late diagnosis, as you can see here. And many of the patients that I see fall into this category. If you get them this early, then you have 90% survival. But this has been the catch. And for us, one of the questions that we were asking is, what factors contribute? And we knew that poor survival was due to late diagnosis, which of course, because of the luminal nature, was because of late symptoms. And so we needed early detection and treatment programs. And one of the questions that we had been asking for a long time is, how do we screen for asymptomatic persons for something like esophageal cancer? In terms of the incidence and the mortality, you can see that both, all of this, we call it the esophageal cancer belt. So it's along the East Coast. It's a distinct belt. The incidence varies. It's around 20 to 30 per 100,000. Majority of what you see is esophageal squamous cell carcinoma, as opposed to what you see in the US and in Europe, which is adenocarcinoma. And interestingly, a fifth of the cases we see are less than 40 years old. So we see very young patients. We think there's tremendous genetic diversity, but we quickly noted that this area had not been very well studied in terms of research. And so looking back at some of the early work that we did, apologies, this slide looked to be inverted, but the whole idea of this slide was that the cases had switched from the right to the left. We were seeing many young patients, 8% or less than 30, some were as young as 14, and then predominantly ESCC compared to adenocarcinoma. And then looking at what else we have done, only a small percentage of these patients were resectable. And so we started this program, and this is Dr. Raswhite, who is the current chair of the CT department, but was the then chair of surgery and head of endoscopy. And he did a lot of early work on palliation using stents. And at Tenec, we developed this technique that did not use fluoroscopy, partly because it was not available. And so we've published a lot of work on this. And this, we've looked at stent sizes, small versus large stents. We've looked at what happens if you only use stents for treatment, and then stents for proximal tumors. And when I joined the team, we had refined the technique further to only use measurements for stent placement. As you can see here, our complication rates were not too bad. Out of 1,000 patients, dilations, only 1.9% in terms of perforation rates. And these are the other usual complications that are common across the world for those who place stents. But the important thing was that you can see here the median survival is 250 days. And so for many of these patients, the stents were providing them with a dignified end of life. Last year, we published this series and we looked at 3,800 stents over the 2 decades of work that we had been doing here. You can see our perforation rate was actually dropping because we had gotten really efficient with this. And actually, you put the stent, you treat the perforation. So this was really because of advanced tumors. What we're able to show is that stent placement is safe. It's a good method of palliation, low rates of adverse events, good clinical and technical success, and it can be reproducibly taught. And we also learned that you should not go above 36 French because that increased, and this is 12 centimeters, 12 millimeters, that increases the risk of perforation. And so out of this work, we had been doing training in the region. But one of the things that we also looked at was that you can see here the number of stents we have been placing is increasing. But this is also reflecting the current reality that we are catching more patients, but we are seeing them late. And so it kept pushing us to this question of how do we work on catching them early? So one of the things that grew from this research and clinical work has been the stent training program. And you can see here, we were able to do this. We were running this through the African Esophageal Cancer Consortium. The trainees came to Tenec, we trained them, and then we went for the first group in Dar es Salaam in Tanzania. And they have actually been doing their own trainings and have been very successful in this. And we've replicated this in multiple countries, in Zambia, in Malawi, and we were to go to Mozambique until COVID came along and derailed those plans, and recently planning to go to Ethiopia as well. This picture here shows the stent training exercises, didactics, working around with the stents. This was a partnership with Boston Scientific, who provided these stents for training. And here with David Fleischer going over the different discussions about tumor size, stent diameter, stent choice. And then here we have trainees working on their stent placements. And if you look here, you'll see Catherine Van Loon from UCSF, part of the team. And then I'll talk a little bit about risk factors, and I'll also talk about what we found in our own research. So in low-risk populations, like in Europe and in the US, it's very well established: tobacco and alcohol, low socioeconomic status. In high-risk populations, China, Iran, parts of Africa, then we have tobacco and alcohol, but interestingly, the hazard ratios are not as much as compared to the low-risk populations. We think diet, and this is low selenium, plays a fairly big role. And one of the papers that we did here showed selenium levels in the blood, and there have been efforts to supplement this in fertilizers. And then there's been work on tobacco carcinogens from non-tobacco sources. So this is firewood, wood smoke. And then there's been work on hot temperature and then poor oral health. So looking at polycyclic aromatic hydrocarbons is a breakdown of combustion. The sources are from either smoke or wood smoke or tobacco smoke, chabrel meat, and they're carcinogenic because they cause this mutagenic process. The important thing is that these are biomarkers of individual exposure. So if you measure the metabolites in urine, it's an exposure of how much that particular individual was exposed to this wood smoke. And so we did some look at what has been published, and you can see here in low-risk populations, the medium polycyclic aromatic levels are fairly low. But when you look at high-risk populations, you can see a general trend. They are all elevated. And actually the data from Kenya, from the most recent study that we did at Tenec, is very far above what everyone else has. So we know that high pH exposure is a consistent finding in all the high-risk populations. And so we designed this study that was on asymptomatic subjects. We looked at 300 adults, but only 289 were eligible. 19% were smokers, which was a fairly low number. And we measured 7 metabolites at the CDC through our partners. And you can see here, the red is data from Kenya, gray is data from Iran, Brazil is yellow, and the US data is this orange color. The Kenyan levels of these metabolites was very many times above what the rest of the world was seeing. So we know that there is something that is driving this in our population, and we think that it's connected to the use of wood smoke for heating and for cooking. Interestingly, the women had got twice as much exposure as the men, and especially those who are cooking indoors, but not in smokers. And so we think because of the time they spent in the kitchen, that explained why they were having these numbers. So pH exposure is exceptional in this population and is associated with indoor cooking with wood on open and vented stoves. And we think this will give us some additional room for some more studies in public health intervention. And so high pH exposure is a universal risk factor for esophageal squamous cell carcinoma. However, different populations acquire their main pH exposure from different sources. So the next thing I'll talk about is the research on hot beverages and hot temperatures. And you can see in a systematic review looking at 41 papers, we looked at the ones that talked about tea. Here you can see the ones that had increased risk and decreased risk. And then for coffee, for mate, and for others. And there were some interesting studies done in Iran. If you looked carefully at the case control, they actually showed that the odds ratios, when they were adjusted, increased as you went from warm and less than 65 to very hot tea, more than 70 degrees Celsius. And this was published by Islam. Now, Hayek issued a monograph on the carcinogenity of drinking hot beverages. And this was in 2016, where they talked about drinking very hot beverages at above 65 was classified as probably carcinogenic to humans. And so when we looked at the different mean temperatures and risk of esophageal squamous cell carcinoma in different countries, you can see here for Kenya with the very high temperatures, Tanzania has a similar temperature. And then you compare to the rest of the countries where the temperature was not too far away and the risk was actually, so for those who had high risk, they were having higher temperatures for exposure. Then there's some good work that has been done on poor oral health and tooth loss. And I think the summary of this entire slide is that both of these have been shown to be associated with esophageal squamous cell carcinoma. And we think that changes in the oral microbiome, fluorosis levels affect this exposure. And we think that this is another area for ongoing research. So we have a number of protocols that are currently trying to look at this in more detail. Our colleagues in Eldoret already published this. They are part of the African Consortium, and those in Tanzania. And they both showed the same things, that tooth loss and poor oral hygiene were associated with increased risk for esophageal cancer. So in summary, these risk studies that we've found, we've looked at, of course, we've shown that there's exposure and associations. There's more data required as we do analysis on our case controls, but we've also found areas for intervention. And you can see here, we could work on ventilation, using cook stoves, using chimneys in the housing, changing from wood to charcoal to natural gas, and then educating people on not taking their tea that hot. And then, of course, for poor oral health education and having access to healthcare, to dental care. But all of these require long-term advocacy. So I'll switch gears a little bit and talk about primarily what has been my research work, which has been screening for esophageal cancer. And just to set the stage, for those of you who are not familiar, if you've ever watched an endoscopy procedure, this is what we usually see. This is white light endoscopy. The newer scopes have got these additional imaging modalities and narrowband imaging. And the whole idea is that the light frequency at around 441 nanometers, the absorption changes. And so usually the areas that have dysplasia light up differently when you change to this mode. Then there's Lugel's chromoendoscopy, which is currently considered the gold standard for doing this. And you stain the esophagus with Lugel's iodine, and the unstained areas show up as these white areas because the dysplastic cells do not take up the glycogen, while the normal cells take up the glycogen. That's the whole basis of doing this Lugol's endoscopy. It's the same concept for screening for cervical cancer, and it works the same way. And so around 2010, we came together, a group of people from the National Cancer Institute, that was Sandy Dorsey, Mark Topazian from the Mayo Clinic, this was Roth from the National Cancer Institute, these two pathologists from the University of Nairobi, and then Steve Baggart was a gastroenterologist at Mayo. And we actually recruited and did the first study looking at Lugol's endoscopy in Africa. And we enrolled 300 subjects. We brought them in. They got a screening endoscopy. They did a very long questionnaire. We divided them into 3 zones, which are actually different in terms of climate, soil types. And so this was a mixed, this was a dry zone. This was a mixed zone. This was a very fertile zone. And we were thinking that there would be a difference in terms of what we saw in terms of dysplasia. They all got these screening endoscopies, and you can see these are the dysplastic lesions that we got over time. And we are looking at whether this could be scaled up. And what we did find was interesting. The most important bit was this 14.4% dysplasia rate. So out of 100 people, 14 would have dysplasia. And out of these, 3% had moderate and severe dysplasia, which we classify as high-grade dysplasia. And this is a treatable range. Why is this important? Is that if you go from dysplasia, the next step is carcinoma in situ and then cancer. And so if you focus on treating these people, you'll be able to stop the development of esophageal cancer. This study had never been done in Africa on esophageal squamous carcinoma. And so it provided some very good baseline information on the dysplasia rates. We then asked the question, what would happen if you took relatives of patients who had esophageal cancer and were symptomatic and screened them? And so we did the same study, but now on first-degree relatives. And it was interesting that we found heterogeneity in the dysplasia prevalence between the families. So we think either genetic or environmental factors might have influenced it, but there was some interesting clustering which needs to be studied further in detail. And this connects the hypothesis that genetics plays a very big role for the development of esophageal cancer. The overall dysplasia prevalence was interesting, the same as what we found, 14.7 and 14.4%. So if you compare our study to the rest of the world, this is the one I did, and this is the one the fellow after me did. You can see here, overall dysplasia, this is China, 23%, 28% China, 22% China, Iran, 4%. So our numbers compare, but the population of China is a big fraction of the world. So for them, these percentages would quickly translate to a large number of screenable people. Whereas in Africa, with a smaller population, it looks like screening for esophageal cancer and dysplasia using this method might not be as effective. And that, of course, has made us to ask more questions about how we can improve this. And so moving from inception to reality, currently we know that endoscopy is a gold standard. You need to train endoscopists in doing this. There's a cost to the endoscopy procedures. We need to find out where they can be done, the personnel to do this. And so we knew that implementing this would be quite an undertaking. However, we decided to start with what we have. And so right now we are offering screening endoscopy to any of the first-degree relatives of any person who has a pathology-confirmed tumor comes to our endoscopy unit. And in fact, recently had a physician whose relative had esophageal cancer who came in for a screening endoscopy. And thankfully, we didn't find anything. So I think for scaling this up in Africa, we would need to focus on high incidence counties and high incidence countries, meaning if I was in Malawi, I would focus in the particular districts that have a higher incidence of esophageal cancer because there's more likely that we'll get more dysplasia subjects that way. So now looking at my GloCal project, which was the next project after I did the initial STEP study, which was the dysplasia study, we were now asking what would happen in terms of the data that would be on the genetic side. And so I met Dr. Van Loon during one of the visits to the US for the consortium, and we put together a team of mentors, and we did this project where we were collecting tumor specimens, saliva, and the geographical locale was the same. We also are following the outcomes of these patients who get esophageal cancer and get different modes of treatment, either chemo, radiotherapy, surgery, palliation, or no treatment at all, and they get only hospice. And we want to see what will happen when you follow these patients. We are currently looking at the genomic analysis of some of the specimens, and this will be interesting to see what data we get. But this was a natural progression because remember, we did the historical research, we did the prospective dysplasia study, and now we are looking at the genetics of it. I've also just finished a case control study here at Tenwek, and a number of case controls have been finished across the African countries, and we want to pull this data into one giant genomic-wide association study and see what we get when we analyze those tumor specimens. One of the projects that I worked on was looking at gaps for future research. So we did this systematic review with Geoffrey Buckle, who's at UCSF. And what we did find after we reviewed all these papers was that the areas for working on included evaluation of the safety and efficacy of neoadjuvant therapy in patients with locally advanced disease. We also needed to look at strategies to improve long-term survival, and then comparative effectiveness of modern palliative interventions with a focus on quality of life and overall survival as outcome measures. And this is ongoing. And so we have a combined treatment outcome protocol that is currently among the African sites. These are the ones that are currently active. And we are hoping that we'll be able to get this data and we'll pull these analyses. So this will be interesting to see both the country data and next to the regional data. Now, one of the other things that I have been interested in is, since we are now looking at endoscopic care for both dysplasia, diagnosis, and treatment, we needed to understand what the capacity for this was in Africa. So first we did a walk around. Now, this was a truly walk around. We went through the different countries, and then we developed this survey, which we sent out to the associations, to the surgeons or the gastroenterologists. There were 87 participants in 91 facilities. And what we did find is that, as you can see here in Kenya, majority of the endoscopy happens in the urban centers. And you can see this is where I am. That's the coast down here. This is the eastern part, Kisumu, Kakamega. And then there's large chunks where these are the arid areas where nothing happens. The same pattern was replicated in Zambia and Malawi here and Ethiopia. We also found that if you wanted to get an emergency endoscopy, you were more likely to get it at a private hospital or at a faith-based institution. And most of the public facilities offered diagnostic services, but there were challenges with equipment functioning, repairs, and also training of the endoscopists. The next thing I'll talk about, the third pillar, as I mentioned, is the second pillar is surgical education. For me, as a trainee, I walked through, the pathway of surgery training, and then this was greatly influenced by the people I met. I put here this picture to show the different people. This is Jeff Hallett, who comes almost every year to Tenwek, and this is Renato Fagundes, who's a gastroenterologist from Brazil. All of them have been working on esophageal cancer work and endoscopy work, and he has also been doing a lot of work on esophageal cancer research. Well, when they do come, they also help us with technical support, training of our endoscopy team. And so this has been the other effect of training over the years. One of the things that happened is that as I settled after my training, we started asking what else can we do? And through our partners, we were able to fundraise. One was to set up, this is our unit. This was the first ever ERCP done within our own unit without having to do it in the main theater. We got, the CM through grants and donations. We got an anesthesia machine. We got a full-time anesthetist. And now we run 24-hour, 7-day available on-demand ERCP service. And so this has been a good example of the impact of collaborations in clinical care that began as research work, because different people came together over the years to help support our unit, and we've now moved from diagnostic care to interventional endoscopy. And we described this process of training for setting up this ERCP service in a rural setup. We looked at the patient and trainee outcomes, and we were able to show that the fellows who were trained were able to have very good outcomes and were able to transition to independent practice. And one of the interesting questions that came out of here was, what does this mean for training in our region? Because the numbers required for training in Europe and in the US are very different from the actual numbers that we had available walking into our clinic. So we thought that if you looked at competency acquisition, that number was going to be different, but we were able to show that this can be successfully done. The key thing is that the people who are doing the training have to commit to coming regularly and to support the trainees. You can see here the impact at the beginning in 2011. These were the counties we were serving, and these are the number of procedures that we were doing. You can see there were very few. And now the number has improved, greatly increased, and we're also getting referrals, not just within Kenya, but outside the country who come in for ERCP services. The other thing that happened was that we were supporting other units. Here I was in Tanzania, in Moshi, showing them how to do lugal scoma endoscopy. And this is something that I've continued to do through my collaborations in COSEXA, AFREC, and the Pan-African Academy of Christian Surgeons across the region, is to support units in endoscopy training or have them come to our units. And so coming soon, we'll be doing a surgical endoscopy fellowship based at our hospital, because the idea is we felt there's a need to train surgeons in endoscopy training. This picture is just to show you my life with the surgical trainees. We do basic science trainings. The journey in surgery training is long, and often you are sleep deprived, as all of you know. And so you can never pass on an opportunity to take a nap, whether it is in theater or out on retreats. And even during long cases, this is tongue in cheek, but all of these people actually successfully finished their trainings and are now practicing specialists in various parts of our country. As part of my life as a surgeon, this was one night. We were pulling out arrows left, right, and center. And so I put this up just to show that sometimes you don't know what will show up. And this is interesting, both in clinical care and in research. And you have often to work with what you have and to adapt to the conditions that present themselves. And for all of these patients, they all lived, they all went home. And we have little mementos here that we've kept over the years, unless they are taken away as evidence. But this was one night that I have etched in my memory because of all this operating that we did on this day. The fun part of the surgical career is this picture is shared with consent when the patients get better and are able to go home. This particular picture is special because this patient was in the hospital for a really, really long time. And at the end of it all, she was just grateful that she was able to navigate a complex surgical stay. And so it's one of the joys of being able to offer care, that we can do this for patients. And of course, we celebrate milestones together. This was the last graduation. And this gentleman here was finishing his training. Dr. Odongo is now gone on to practice by himself. And one of the things that has happened over the years is the impact of our training has been improving the number of women surgeons. Of course, in surgery, in the earlier years, it was more male-dominated. And now we actively have been seeking to ensure that we work on this. And so every year, we always take female trainees. And actually, in Kenya, we took this a step further. And so as a secretary, I would often join them. Actually, I've never missed any of their meetings when they do these ladies' conferences, and we would show up and support them. You can see here, president of COSEXA, president of the Surgical Society, and myself, just being with them and discussing pertinent issues. And so the collaborations in clinical care, we allow ourselves to learn from each other, exposure to new cultures. You can pass on the vision. And I actually want to thank FACS because they've been funding trips for these residents to come. And you can see here, Dr. Asaf was playing with our little $10 box trainer that is made of cardboard. And by the time he was done with us, after 2 months, he went back to his site and would be able to carry out endoscopic procedures. So we've actually looked at this. We looked at the training for surgical trainees in Africa, and we published this paper. And what we did show was that by the time they were getting towards their senior years, they were actually more independent, and they were looking towards doing procedures on their own, which is what we were actually expecting. As part of my work with COSEXA, we've been increasing the number of trainees in the region. And you can see here over the last decade and a half, we actually reached our goal of 500 surgeons by 2020, which was a big milestone. And this has really impacted provision of surgical care in the region. Now, the other part has been through FACS and ECSA. We've been actively engaged in leadership. This is Russ White, who has been one of my mentors. He was the past chair of the training committee, and now I've taken over from him. And here is Ntumba, who is the president of the Surgical Society. All of these are now faculty at the institutions. They're all training surgeons. So it's just the impact of when you train one person and they go on to train others. That and I'm really grateful that GloCal is making this possible on the research side. And so we've been looking at the impact of this, and there's a number of papers we've published looking at what has happened when these trainees go out there. And what we've shown is that we have been able to retain more than 95% of the surgeons that we've been training in the African continent. And this has been really massive to combat brain drain and to provide care for our patients. And of course, when they finish, we help them to settle and plug them into various sites. Fadipa is now one of our faculty. Sam has moved on to one of the sites. This guy is a fellow in cardiothoracic training, and she is working at one of the training sites in the city. So all of them have been doing something, and you can see here the impact that FACS has had on the African continent in terms of placing surgeons all over the continent. And so this is really a good thing to just demonstrate. Finally, I'll move on to mentorship in the last 5 minutes, and then I'll open up the floor. I think mentorship plays a big role, and I put this slide up just to appreciate the different mentors I've had over the years. Of course, you've seen Russ White a few times. This is John Tapley from Vanderbilt, who's done a lot of work on global surgery. And this is Sandy Dorsey from the NCI, who has worked with me on my esophageal cancer research journey right from the beginning. And we've shared many podiums and platforms talking about mentorship and research. And this is Abebe from the College of Surgeons, who we've spent a lot of time doing training and examinations for the college. So I just want to underscore the importance of having the right mentor to be a catalyst in your own individual journey, which for me really played a big role. And so one of the things that I have enjoyed doing has been working with trainees. You can see here, doing basic suturing skills when they come for as interns. And then eventually, like this is Simel, he joined our fellowship program for research. And then he actually went on to join our surgery training program and is now almost done with his training. He's in his third year. He was able to do an MPH while at it. And so it's good to look for opportunities, not just to do this, but to pass it on to others. And of course, when they do well, you enjoy basking in the reflected light. You can see here, Dr. Otoki got an abstract accepted at the American College meeting, and it was a joy to watch her do this presentation last year. And so I think mentorship is one of the things that we really need to keep on underscoring, and I want to thank the team at GloCal for making this happen. So as I finished my own journey in research, began with a catalytic grant from Aortic and the National Cancer Institute. This was a big cut grant, and that funded my first study. I joined the ACLI, the African Cancer Leadership Institute, and that connected me to a large group of mentors. And then I decided to follow this pathway into endoscopy training for 2 years, then did surgery, residency, and completed that. And at the end of that, I did the GloCal fellowship. And while this was all going on, we formed AFREC, and this expanded the reach as well as the number of things we were able to do. Plus, a few more collaborative grants came in. I recently just got a grant from the UK. This was the Fellowship for Rural, Remote, and Humanitarian Surgeons, and this was focused on endoscopy capacity building. I did this for the last 1 year, and also in the same year, I was able to do a Surgical Education and Leadership Fellowship because I've been really interested on developing the surgical education space. And currently, I'm working on a giant UK-Kenya ongoing esophageal cancer research project that is being run by the Kenyatta University Teaching Research and Referral Hospital. And I've been joining the team as one of the endoscopy consulting leads looking at the research. So really, I'm really grateful for the different mentors I had across all of these steps and what they did to help push me along this pathway. So what does the future look like? And I put these pictures just to juxtapose. So this is us at Tenwek playing with our little box trainer, which is made from, these are little wine stoppers that we recycle. And we can teach snaring and simple retroflexion, moving of things, biopsying on this thing. And in 2021, I got a grant an award from the American College of Surgeons because of my work on surgical oncology research. And so I was able to spend a month in the US at various sites. And one of the things that I enjoyed was watching them do surgeries on the Da Vinci robot. And for me to juxtapose what we are doing and what is currently going on, and asking myself the question of, as we all technologically advance, at some point, I know that even in Africa, we will be able to get to this. We've been able to do that for laparoscopy, and I know this will come in other spheres. So I think that the future will involve engaging, for GloCal, the alumni in, leadership and other positions, surgical alumni in leadership and training programs, exchanges that are going on for collaborative building, mentorship and sponsorship, missions, both medical and otherwise, volunteerism in other parts of the world. And then, of course, research collaborations, because now we are all connected through the internet. And so this is very exciting to look at what can happen in the next 10 years. And so during COVID, I was able to put down some of my thoughts on mentorship in a book. It's actually available on Amazon for those of you in the US. And really, I think one of the things that I really enjoyed talking about was the impact of mentorship and sponsorship. And so for me, I have enjoyed looking for opportunities to make this happen now for my current trainees, because other people did this for me and allowed me to go for regional meetings where I was able to network, meet new people, get other grants. And I think one of the quotes that really I ended up putting in the book was that sometimes the struggle or fear is that our mentees can eclipse their mentors. But in my opinion, this is the ultimate prize of good mentorship and allows the mentor to bask in the reflected light of the success of their mentees. And so I hope that for all of you who are fellows, that when you move on and to do other things, that you look for opportunities to pass this on to others. And so I go back to where I started, that for us to continue impacting the next generation, I think training in various spheres, whether it is in surgery, in research, and all of these are interconnected, is really the way to go, because we will not only impact each of these individual people, but we will be impacting the next generation that they will take care of. Thank you very much. Let me stop there. I hope we are on time, and I'll give it back to Dr. Lee. Thank you.
Well, Michael, thank you so much. This was such a treat, and I think you covered such a broad range of important topics, including, sharing your research as well as your support for training the next generation of surgeons, as well as your platform on the importance of mentoring. And I think I can speak for all of us. This was such a great time with you. And I know that some of our trainees already have some questions, and I wanted to start us off with this thought that I had about, when you look at the PAH exposure as a potential risk factor, I was thinking about, using the early detection of esophageal cancer as a gateway to potentially screen for other types of cancer. So in terms of PAH exposure, I know, especially in like a lot of countries in Asia region, where women are predominantly more exposed to indoor smoke because of their role. And I've heard that that could be for non-smokers the risk factor for lung cancer. So I was wondering if you can comment on that, and then we can open the floor. And then the other thought I had was, like in Asia, in Korea, China, Vietnam, some of us are from Asia. Spicy food is really common, and I was wondering if you can comment on the risk of spicy food on esophageal cancer.
Oh, yeah, I had to unmute. Thank you very much. And this is interesting. So one of the questions that we actually looked at was that particular question of incidence of lung cancers, because it's very fascinating. We don't have as much lung cancer here in this population. But now that we've identified a particular exposure that is connected to the cancer, I know that this could be actually a good study to look, because I think one of the bases of good research is to ask the question and then to go see what is there. So actually, I'm going to pose this to the team here and see if somebody will bite and see if we can look, especially at our population, because we have a very distinct region that we can study. But to go back to your initial question, the lung cancer rate for our part of the world is not as high as what you see there. But definitely, I've made a note of this, and I'm going to because now I'm really curious whether we'll actually get anything if we dig between the pathology confirmed, even if there are few, we see if we can work backwards and look at their exposures that they have in their own living situation. So that's a good research project. The second question you had was about the spices. Now, the part of the world, the part of the country I live in. So Bomet is not very keen on spices. I think the people here don't take much spice. I think the closest they call a spice is avocado and salt. But there are parts of Kenya, like the coast, where we see an increased number of esophageal cancer patients. And so when you look at our case control data, I'm going to look and see if anything will come up related to that. I know we didn't specifically ask them about spices. So this would need probably a new study design. But I can say so far that hasn't come up as a strong risk factor for esophageal cancer. The thermal component has really come up as a strong component connected to esophageal cancer.
Yeah. So, well, thank you so much. So we have, let's see, a couple of questions. So Grant, you can elaborate by unmuting, but I'm reading your question. So what have you identified as some of the barriers preventing young researchers from building successful collaborations?
Okay, so that's a really good question, partly because I had to find a way to navigate that barrier myself. So you realize that when you begin your career, you have two choices you need to make. One, do you want to spend the time to settle in especially if you're doing like surgery or a clinical oriented career where you would need some time to settle? There are those initial years which are foundational. Or two, do you want to switch, which is what I did. I finished my training and I simply went back into research. But I had such a team around me that it allowed me to continue doing both, working on my surgical side and working on my research side. The most difficult part was finding protected time. And I think, especially if you're not working in a research institution, most of them would not understand why you need a day off or 2 days off to go off and collect data or work on data. And so some of the mechanisms that GloCal provides allows you to do that because they know you have some time built in to do this. But how we solved it here was to have a discussion with the administration and, with my direct supervisors and help them see. And I remember we did a chat for them on PubMed. We searched all the papers that had come out of our hospital and we made for them a graph and we showed how it was growing over the years. And we said, hey, for us to keep doing this, you need to allow those who are doing research some time. And so on the surgical department, we as a team agreed to give each faculty some time to work on research or admin as is dependent. So I know one of the things that you'd have to navigate is finding protected time to work on your research career. Now, the second bit is funding. So once your fellowship ends, if you don't have a grant or you don't have a mechanism to keep it going, most people who started as researchers ended up switching back to clinical care because they couldn't keep up with taking care of family. And so for us, that's a really important decision that people have to make. And so I'm really grateful for the sites in Kenya that have allowed people to do research and have supported them to do research. So I think that's a really critical thing. And then the third thing is having the right mentor will push you in the right direction or tell you, please don't chase this. I did this 10 years ago and it did not work. Or if you want to chase it, find something new that you want to chase. Because I know the frustration of having failures or rejections can sometimes make you to stop chasing a particular pathway into research. And maybe this is a good time to talk about, I think my first paper took 2 years to get accepted. And in the middle of the second year, I almost gave up. I was like, all of these guys keep saying no and giving me reasons why I should revise. But eventually it got accepted. And the funny thing was it got accepted into a really high impact journal that I didn't even realize it until one of my mentors said, hey, Mike, I hope you realize the importance of you getting this paper into this particular journal because it was worth the wait. So sometimes you have to develop, I call it grit. in surgery, the trainees who have grit at the beginning are more likely to survive. It's the same with research. You have to have a little bit of a thick skin or an adversity index that you can survive the failures or the rejections. You apply for a grant and they say no, and you keep trying and trying until eventually you succeed. And then from there, you realize you can make it work. I hope I've answered that question.
Yeah, I mean, I think in terms of publications, I couldn't agree more. I think one of my mentors said, every paper you develop eventually will find a home. It all depends on your resilience and persistence. And I think, yeah, sometimes it takes many, many rejections until you find a right place for your manuscript. I think Ben also had a question, but I think it's similar to the previous question about balancing your time between, OR and research, clinical work and research. I think you covered it quite well. Let's see, okay, so we still have a few more minutes. Any other questions? I think this is such a great opportunity to, get some perspectives and advice from Dr. Mwachiro. And monitor, and then feel free to unmute and then ask questions as well.
So I'll say something just because I was reading one of these questions here. Somebody was asking, this was who? This is Bin Chow. I hope I said that correctly. What advice do you have for young trainees who seek to improve clinical operating skills while building a research career? So how do you find the balance between spending time in the OR and doing research? I will say this, you have to be really intentional. So in my office, and before the office, I had a board. And on that board, I divided it into days, and I wrote Monday, theater, Tuesday, research, Wednesday, endoscopy, Thursday, clinic, Friday, theater. And the reason I did that was so that if I had cases, I would put them up there and know that next week I'm doing, a Whipple or I'm doing a gastrectomy. So you'd hunt for the cases that you don't do a lot and put them up there. And I remember for endoscopy, I would look for opportunities to do specific cases because I really wanted to become proficient. So surgery, like driving, you need to put some time. The more you do it, the more proficient you become. So I would say you need to be really intentional that you put it out there that I need X number of hours for research, X number of hours for the OR, and X number of hours for the clinic, or X number of hours for my trainees. And they know that I live this multifaceted life, so I'm not there all the time, but it helped me to know that I need to spend time in the OR. I can't do all clinic or all research the entire week, especially at the beginning. It's really key. Then once you find your rhythm, it becomes easier. Yeah.
Thank you so much. And I think, your point about the importance of having a really great mentor to support you on your early career. I think that's also very, very key. And I love your perspective about being really intentional about your plan and very detailed, week to week. Let's see. Okay, Ben agrees. Very helpful advice. Thank you. Any other parting last questions for Michael? Okay. All right. So Christine, do you have any announcements or anything?
None that come to mind right now.
Okay.
Thank you all for joining in.
Yeah, and then we have our February career development series planned already, right?
Yes, we do.
Okay. Great. So, well, thank you. Thank you, Michael, for spending your time with us today. And thank you all fellows for being here. And I will see you all in February. All right.
Thank you, and have a great day.
All right. Thank you. Take care.